From there, we will look at our objectives. I'm Dr. Rayan consultant obstetrics and gynecology and assistant professor at Marfa University. So when we talk about our lecture objectives, we'll be explaining the components and objectives of a prenatal and antenatal care goals. We'll describe the frequency and aim of each prenatal visit, describe the genetic counseling and its available tools, and discuss risks and benefit of the genetic tests. So we're supposed by the end of this lecture to know how to plan and discuss the antenatal care, define the antenatal care, and provide an optimum antenatal care plan for our patients. First, we'll start with the definition. So it's the professional care that the woman get prior to labor and delivery in order to diagnose disease or complicating obstetric conditions without symptoms and to provide information about lifestyle, pregnancy, and delivery. The three basic components of prenatal care are: first, early and continuing risk assessment, ongoing evaluation of the health status of both mother and fetus, the medical and psychosocial intervention, health promotion by patient education and communication. So an antenatal care is not just a single visit, it's a program and an intervention that will require a journey with a specific program and milestones or stations. When we go to the main antenatal care components, we'll be talking about history, physical examination, laboratory tests, diagnostic imaging, patient education, and medication. Under each of those, we have to provide the needed skills and required knowledge to perform an optimum antenatal care. Starting by history, I would believe that you already took the history taking and physical examination lecture, but we will go fast about the history. So it will depend on personal and demographic information, current pregnancy status, and the dating, past obstetrical history, the time, place, gestational age where she delivered, when delivery happened, any complications, the sex of the baby, weight, and the current status of the baby, healthy, alive, or have any difficulties, may God forbid. The personal and family medical history, the past surgical history, genetic history, of course, the menstrual and gynecological history, and the psychosocial information. When we go for risk identification, from the history, we will identify women whose health may be seriously jeopardized by the pregnancy. And here we might recommend even that pregnancy might be seriously affecting the patient health or even survival. So it can lead to maternal mortality. Some of them will be affecting the pregnancy and will need special care, or we will consider this as a high-risk pregnancy regarding the mother status. So they should be counseled about the option of terminating pregnancy if there is a risk of maternal mortality or major morbidity for the mother. Also in the risk identification, we should be looking such as reproductive history for preterm birth, low birth weight, and preeclampsia, stillbirth, congenital anomalies, previous diabetes or gestational diabetes. And it's very important to identify, even not in the first antenatal visit, but in the prenatal care visit. That means before pregnancy even. One of the main important information that we need to confirm and be very assured about is the fetal gestational age. And as you all know, that we take the gestational age based on the last menstrual period and we calculate from there the gestational age, the expected date of delivery, and by this we'll be planning our visits. So how we can, what we will use for that, either we'll use the Nigel rule for expecting the date of delivery, and we can use the obstetric wheel or the obstetric programs for calculating the gestational age. But it's very important to confirm that this is the last minister period was a reliable last minister period, and this is confirmed by having she will be assured about her date. We ensure that we take the first date of that last minister period, not the last day or when she finished and from the cycle, and she should have a regular cycle, and she was away from contraceptive for more than 3 months, oral contraceptive or hormonal contraceptives. If we have any doubt, we can confirm with ultrasound, especially in the first trimester. About physical examination, a complete physical examination is always needed for those patients, especially in the first visit. But we will add to that uterine size and shape, evaluation of the adnexia, baseline, blood pressure, weight, and height should be recorded. This is a diagram or a picture that shows the important examination that should be taken for a pregnant lady. Confirm pregnancy and determine viability. So the first visit, this should be in the first 12 weeks. We will be confirming pregnancy and determining viability of the pregnancy. This is in the first visit. So how we can confirm pregnancy? First, that patient will be reporting that she missed her cycle from the expected date. Then we do a pregnancy test, either urine pregnancy test or a blood pregnancy test. However, patient might be mistaking a first antenatal, first trimester bleeding with an irregular cycle. So by as 30 to 40% of our pregnant ladies might have an early bleeding in the pregnancy, and this not all will be a risk of abortion or ectopic. Some will be a physiologic manifestation for implantation bleeding. Therefore, a pregnancy test should be performed in all women who have abnormal vaginal bleeding, or they come for any intervention. If they are in the fertile group and they have irregular cycle or they miss the cycle, do a pregnancy test. So we have two types of the pregnancy test. We have the quantitative and the qualitative. For the qualitative, we will check positive or negative, and this can be through urine or blood. But for the quantitative, we go for a serum blood test. The first HCG molecule is first detectable in the serum 6 to 8 days after ovulation. A titer of less than 5 is considered negative. Between 5 and 25 is equivocal. Above 25 and above is positive. And a concentration of about 100 international units per liter is reached about the date of expected menses, يعني على the day of the cycle, expected of the day of the cycle. For the lab test in the first visit, we do a standard panel of laboratory tests, which include CBC, blood grouping, and antibody screen, hepatitis B antigen, torch investigation, urine analysis, cervical pap smear if you don't have a recent one, and she's married or for more than 5 years or more or from the first intercourse, and a pregnancy test is included in the first visit. The pregnancy test, as we talked previously, it is checked 70 days after the first missed period, becomes positive on the first day of missed period. Serum pregnancy test is classically becomes positive 5 to 7 days before the first missed period, a week, almost a week before the expected date of her menses, with a normal intrauterine pregnancy. The HCG level doubles approximately every 48 hours, 36 to 48 hours. Just remember that usually it doubles at 48 hours, or at least 60% should be increased. This is a device or a tool for getting a pregnancy test. And here we have the C and the T in the first gasket. And usually we take the early morning urine sample, and it will be placed at the sample hole, and then you will look at the results. If you have two, so this is a positive. If you have the control is positive, the test is there is no line, this is negative. If you have the test is positive, the control has no line, this means it is invalid, and it's not reliable. You need to repeat it with another new checkup test. Additional lab tests in the first visit. This is considered in high-risk populations, and it depends on the population you are practicing in or you are having in your clinic. So we might do the chlamydia swab, HIV, thyroid function tests, and the blood sugar. Other additional lab tests would include gonorrhea, TB, hepatitis C, bacterial vaginosis, and hemoglobin electrophoresis, cystic fibrosis, phenylalanine level, and this is based on cases or, as we mentioned, the background of those patients. In the follow-up visits, major goals is to look for PET, GDM, malpresentations, anomalies, and check the fetal growth. Also, you will be looking at the patient weight, vital signs, fundal height, and auscultation for the fetal heart. Also, for fetal movement, lie, and the presentation. You will be answering the patient concerns. You will be educating the patient about pregnancy and the symptoms of pregnancy and what is expected. You will be identifying the risks that might be developing for this patient. This is a table that shows the component for a routine perinatal examination. It will have the fundal height, the measurement, urine analysis, and the weight measurement, plus the vital signs. Like what a patient education involved in the following is the following. You will always talk to the patient, especially in the early, or if you find an abnormal weight gain, about diet and weight gain. You will be talking about medication and supplements like vitamins. You will ensure that they will avoid radiation and how to deal if they will need to have an X-ray for a teeth or for chest or other radiation exposure. You will be giving them the self-care during pregnancy, minor complaints, answers, smoking cessation if they are smoking, alcohol consumption, and education about risk of having the alcohol in pregnancy, immunization, air travel education, and the breastfeeding, and this usually toward the end of the pregnancy before delivery. Regarding the nutrition advice, folic acid is needed till 12 weeks, and here we use 400 microgram or a 4 milligram tablets. This is the dose, but we have in the market is 5 milligram or 1 milligram dose. Here, from 400 microgram, 0.4 milligram to up to 4 milligram. In the market, we don't have. طبعا هذه high dose and low dose. We have 1 milligram and 5 milligram. It's okay as folic acid is excreted in the urine, so no worries, you can recommend it to your patient. However, you have to identify which patient will be using the high dose or which one will be using the low dose. Eat healthy, balanced diet, and this is around 2,500 kilocalories per day. Drink enough fluids, 1.5 to 2 liters of water and fluids, plus any replacement for excessive fluid, for sweating or fluid loss, like in vomiting or diarrhea. Moderate caffeine intake, and this should not increase more than 200 milligram. Avoid uncooked or undercooked ready prepared meals of eggs or meat, especially chicken. يعني cold cuts should be avoided as the risk of bacteria to develop is higher. Fish intake should be no more than 340 grams per week. Avoid fish types high in heavy metal like sardine and mackerel. Iron needs double in pregnancy, so at 27 milligram of iron daily is needed. Women should be avoid fasting more than 13 to 14 hours without food or skipping meals. And this is reflect on our timing now in the fasting in Ramadan. So always advise your patient to have a small snack at sahur as late as possible before Fajr prayer, and to have early breakfast as Al Maghrib prayer is launched and breakfast is started. They should have 5 meals per day, 4 to 5 meals per day. This is the expected. طبعا 2 to 3 main meals with small meals in between. What is the expected weight gain? So for a normal weight, we would expect at 11 to 16 kilograms increase. For an underweight patient, we expect 12.6 to 18 kilogram increase. For an overweight woman, we will be having 7 to 11 or 12 kilograms increase. In case of twins or multi-fetuses, women should gain an extra 4 to 6 pounds in the first trimester and 1.5 pounds per week in second and third trimester, for a total of 35 to 45 pounds. يعني around تقريبا 17 to 22 kgs in the pregnancy. Elevating unpleasant symptoms during pregnancy. A lot of symptoms that can come. It can be a sign of disease, usually in people, non-pregnant ladies. Like in pregnancy, it comes with the complaint of pregnancy. So طبعا the number one is nausea and vomiting, especially in the early first trimester. This complicates 70% of pregnancies. We advise them to eat small, frequent meals, avoid greasy and spicy foods, protein snacks at night, salt and crackers at the bedside is an non-pharmacological approach. Antihistamine appear to be the drug of choice, and other medication like vitamin B complex. Usually we give the Vuminor or Metoprolol as a first choice, اللي هو ميكلازين medication, or we can go to others like metoclopramide, or and severe cases we go for the Zoron. We evaluate for possible secondary causes like twin pregnancy. لا قدر الله يكون في diarrhea يكون في food poisoning or other causes, GERD, as any other patient. Heartburn, it affects about 2/3 of the women at some stage of pregnancy, resulting from progesterone induced relaxation of the esophageal sphincter. We should always advise them to avoid lying down immediately after meals. Antacid can be used. Usually we give the chewable medication like Rene or Gavexin. If it doesn't work, we go for PPIs like Nexium and others. Constipation, this is also secondary to decrease of colonic motility. Dietary modification, including increased fiber and water intake, can help lessen this problem. Nerves may be used in combination with bulking agents, and we know that we treat constipation by different pharmacological agents. Some of them are stool softeners, some are laxatives, and others are bulking agents. So usually we depend on stool softeners and bulking agent for as a prevention. We might use some laxative, but with mild laxative uh, features for short-term use, only in cases with severe, not responding or refractory cases. Because sometimes if you give inducing agents or laxative agent, you can get the patient into labor. Hemorrhoids also is a complication that may be caused by pregnancy. This is increased venous pressure in the rectum, increased rest with elevation of the legs and avoidance of constipation are recommended. This for hemorrhoids and also in simultaneously, those patients can have leg cramps with varicose veins. Those patients with leg cramps and varicosities are experienced by almost half of all pregnant women. Massage insertion may offer some relief during attack. Both calcium and sodium chloride appear to help reduce the leg cramp in pregnancy. Back aches, very common. This is secondary to the posture change during pregnancy and the change in the curvature of the spinal column. Also, due to uterine enlargement and the change of the center of gravity for that patient. We avoid those patients to control their weight gain, not to have excessive weight gain. Also, to use exercise, support their back muscles. Also, use sensible shoes and may use the shape pillows and the mattresses with good support for the back, not use the very soft mattresses. Nasal stiffness, this can come and very common in pregnant lady. They will feel some edema or nasal congestion. This is due to estrogen levels increase, and intervention can be saline drops or humidifier اللي هو البخاخات او اللي هو جهاز حق جهاز حق السلاين والبخار. Breast enlargement and tenderness, these are caused by estrogen and progesterone levels, as now the breast will be increasing to start formulating breast glands that will be forming milk. Here you can advise them that this is normal to have. Pain might be more in the beginning or in the first trimester, but it will ease on. You advise them to use the support bra with wide shoulder straps. If they feel this due to cold weather, they can have good warm by having jacket and sweaters. Shortness of breath, also common. They will feel their breathing and they might feel some dyspnea. Causes are pressure of the uterus on the diaphragm and compression of lungs. More at night when flat. Intervention should be having a pillow or more that will support their position. And when they sit, they should be sitting upright. This will help them to breathe easily. Ankle edema. This causes due to fluid retention and poor venous return from lower extremities. This is aggravated by the prolonged sitting or standing and also by the warm weather. Who care near term intervention should be raise the legs, avoid tight fitting pants, and you can use the supporting stocks. Urinary frequency and urgency. This is common in pregnancy due to increased dynamic circulation. However, also risk of urine infection is there. Quite a good number of patients might have urine infection and they will not be sensing a difference from the usual pregnancy complaints of frequency. They might miss the feeling of having dysuria. So with follow-up visit, you need to do a monthly or every 6 weeks in the beginning a checkup for urine analysis, checking for infection and also for protein. Also for nitrates as a sign of infection, leukocytes or blood or squamous cells or others. For the intervention, they always check for urine analysis and culture and prescribe the antibiotic when needed. Reduce the caffeine and the citrus food and spicy foods. Do Kegels exercise and plan frequent stops. For increased vaginal discharge, you have to do leukorrhea. For increased vaginal discharge, which is the leukorrhea, the causes are estrogen and blood supply to vagina and hyperplasia of the vaginal mucosa. This with the changes that happen in the genital system of the patient in pregnancy and the ability for the vulva and the vagina to accommodate the baby during delivery and support the patient delivery. The intervention, daily bath, sanitary pads are okay, but no tampons that is inserted inside the vagina. Tight pants or underwear should be avoided as infection will increase. If they are having pleuritis or erythema, this might be a fungal infection and vaginal culture can be taken, and we can use the topical medication or local medication for treatment. For exercise, women should be advised to continue to exercise during pregnancy unless what? Those patients who have risk factors for abortion or having abnormal bleeding during pregnancy, patients who have risk of preterm labor or having complaints of preterm labor, having dynamic cervix or risk of having or an open cervix, risk of preterm rupture of membrane. Those are not advised to have exercise. Like what type of exercise that we should advise them, or it should be not a high tone exercise. It should be helping the patient to stretch and strengthen their muscles, especially the core muscles and their pelvic floor muscles. They should be avoiding any exercise on the abdomen. So it should be on the back if they're going to lay down or standing. Also, any exercise that need balancing or one leg balance, standing on one leg, this should be avoided. Patient should be always advised to ensure well hydration and avoid hot places like sauna. Smoking and pregnancy. Smoking increases miscarriage rate and the risk of ectopic pregnancy is increased, and this is due to affecting of the cilia of the fallopian tubes and the movement of the contraction of the fallopian tube muscles. Also, risk of placenta previa and placenta abruption are increased. Risk of premature rupture of membranes and preterm delivery is increased. There is increased risk of cleft palate deformity of the fetus, and increased perinatal mortality and birth weight, and a low birth weight by an average of 200 grams. So low birth weight and the perinatal morbidity and mortality of the fetus is increased with smoking. Immunization. We advise that influenza vaccine is a seasonal vaccine, should be taken throughout October to May. Undergo inactivated influenza vaccine. We don't take any live attenuated vaccines during pregnancy. We don't take live vaccines in pregnancy. What about tetanus, diphtheria, and pertussis? This is called the Tdap vaccination, and now it is recommended for the patient and also to protect the fetus, and ideally taken between 27 and 36 weeks of gestation. so immunity will be extended to the fetus. Traveling is acceptable under most circumstances. However, risk of traveling to endemic areas should be avoided, or taken if really necessary. They need to take the special vaccines and precautions or medication that would help them, like going for a malaria infected place or other endemic areas. What is the risk during pregnancy? طبعا long trips are a risk for thrombosis. That's why we try to avoid long trips. If long trips are needed, we have to walk every 1 to 2 hours, do exercise for lower limbs. We have to be hydrated, and we might use blood thinners to avoid clotting. And طبعا avoid rough trips. If we are going any off-road trips, is not recommended because of the increased bumps in the road. طيب. In examination, we'll be looking for now the presentation and the lie of the fetus. So in the presentation of the fetus, the lie is the baby relation of the wrong axis to the fetus, and from the fetus to the mother. Only a longitudinal lie is normal, oblique or transverse is abnormal. The presenting part is the area which is most near to the pelvic outlet, and we can see breech is when the head is up, buttocks is down, and cephalic is when the head is down. Around 97% of patients will be presenting as cephalic during intern pregnancy. Much less than that, and during the 8 or 7 months, it goes to 30% almost are non-cephalic. But during term, only less than 3% are non-cephalic presentation. Follow-up visits in uncomplicated pregnancy, يعني the routine antenatal care, it is every 4 to 6 weeks until 28 weeks, then every 2 to 3 weeks from 28 to 36 weeks, and then weekly until delivery. This is the optimum. However, we don't have, not everybody have accessibility to healthcare or optimum healthcare. We might need to go for the WHO recommendation, which is minimum visit. Previously, it was 4 antenatal care visits for a low-risk pregnancy. However, this has been changed, and now the least recommended is 8 visits. 1 in the first trimester, in the first 12 weeks, then 2 in the second trimester, and 5 in the third trimester, to have an include 8. This is in a normal 40 weeks pregnancies. However, if patient is beyond 40, they will need to add 1 more visit at 41 weeks plus, and plan delivery for those patients. So this is the change from based on optimum and the least visits for a low risk pregnancy. Of course, this might change for higher risk or special pregnancies. The follow-up visits, laboratories, we need to do GDM screening, and this is usually for low-risk patient to be at between 24 and 28 weeks, يعني بين السادس والسابع. Also, we will do CBC and antibodies and GB screening with a rectovaginal swab. This is done at the third trimester near to delivery, and this is need to be done for patient who will be delivering a normal delivery. What is GBS? GBS is the group B streptococcus infection. This can cause significant neonatal morbidity and mortality, especially among premature infants, and this should be offered for all pregnant ladies at term who will be delivering a normal delivery, not cesarean section. Screening is usually between 35 and 37 weeks of gestation, يعني prior to labor. No treatment needed when found prior to labor in high vaginal swab. but if it was in urine, you have to treat it because this is not normal to have a GBS. By the way, 10% of patients, they might have GBS positive and within the normal flora of the vagina, and usually it doesn't need treatment if no symptoms is there. However, in pregnancy, and they are going to deliver normally, you will need to cover those patients during labor with intrapartum antibiotic to prevent the transmission and affecting the fetus. Diagnostic imaging, we do ultrasound or MRI. Both are safe in pregnancy. However, which is the most affordable and accessible and easiest is ultrasound. MRI is reserved for cases with risk of abnormal placenta attachment, like placenta pericarita, accreta, or risk of if fetus need more detailed scanning or there are multiple anomaly, you might consider MRI, but the gold standard for pregnant lady is to use the ultrasound. When we will be doing ultrasound, this is first in the first trimester, and here we do it to confirm pregnancy. أو شيء يعني pregnancy is there, viability, assess gestational age, also assess the chorioniosity and amniosity, maternal pelvic anomalies if there is previous history of pelvic anomalies, or there is abnormal diseases in the pelvis. Also, we'll do something called the knuckle translucency in the first trimester. طيب. How we will be using the ultrasound for estimating the gestational age? The measurement of the fetal crown rump length between 6 and 11 weeks of gestation can define gestational age to an estimation within maximum 7 days difference. So it is very accurate. And this is the, if you want to confirm the gestational age, we use the crown rump length. And you can see the ultrasound here, and you can see the pointers show at the crown of the fetus and also on the rump or the end of the fetus. And by that, we can estimate the gestational age with a high accuracy. However, if we miss this, the patient is not there, and we have them later than that. So between 12 and 20 weeks gestation, age can be determined within 10 days difference. But here we'll be using the biparietal diameter is the most accurate. Femur is less and abdominal head circumference are lesser. So if we are going to do at 12 to 20 weeks, we depend on the biparietal diameter. However, thereafter, measurement becomes less reliable with advancing gestational age and can increase up to 3 weeks difference in the third trimester. So it's not reliable to determine the gestational age. The best is in the first 6 to 12 weeks and to a lesser extent in the second trimester. Right. Viability. Here we have to determine viability. Of course, if you have a fetus without a pulsation, this is non-viable. But we have other cases like we have the oblated ovum or an empty gestational sac. And if this sac is 8 millimeter without a demonstrable yolk sac, then this is considered as missed abortion or oblated ovum. 16 millimeter without a demonstrable embryo, then also this is a sign. Yeah, you have a yolk sac, but you don't have an embryo, then this is considered oblated ovum or a miscarriage. The third case is when you have an absent fetal cardiac motion and in an embryo with a crown rump length of greater than 5 millimeters. However, in any of these cases, whenever you don't find or you are doubting the viability, you have to confirm. Don't announce right away and take an action because odds are always there in medicine. So you have to give them, you can repeat the evaluation in 1 week, or you can do a beta SCG, a serial beta SCG. And as we mentioned, it should be increasing, almost doubling in every 48 hours. If it is less than 60%, then this is not a normal pregnancy, or if it's not, it should not be increasing if it's a miscarriage, or it should be decreasing. So we can do either we repeat a gestation, an ultrasound, or we do serial BTCG. In the second trimester, while we do the طبعا احنا we do the NT. Just see. We'll talk about the NT, also is done in the first trimester, but we'll talk during genetic screening. However, it is done in the first trimester between 11 weeks and 13 plus 6 days. Second trimester ultrasound, we do here the fetal anomaly scan. And here we'll be looking at the head shape, the size, and internal structure of the fetus. We will be looking at the spine, longitudinal and transverse, abdominal shape and content, abdominal shape at the level of the stomach and at the level of the kidney and the umbilicus. We do renal pelvis measurement. It should be less than 5 millimeter in the anterior posterior measurement. And we do a longitudinal abscess, abdominal thoracic appearance. We will be checking the diaphragm and the bladder. Also, we'll be checking the thorax at the level of the four-chamber cardiac view. However, sometimes this at 20 weeks is not very clear, and we wait for 24 weeks, or we redo this view at 24 weeks. Arms should have 3 bones and a hand, not counting the finger. Legs, we have 3 bones and a foot, and we don't, without counting the toes. However, always remember that ultrasound in pregnancy will detect only 50% of the congenital anomalies, and small congenital anomalies might be missed up to 50% in the cases, yani a percentage. In the third trimester ultrasound, here we do it when indicated. And here, if you have a discrepancy between the fundal height and the gestational age, or if the patient is coming without knowing her gestational age, you want to check the gestational age, then you can do this. Or if you want to make sure that this fetus is healthy and is having a normal growth, you can do 2 ultrasound to check the weight gain and the growth. Also can do something called the biophysical profile. And in cases when you are doubting that this is the presenting part is cephalic, or you're doubting the lie of the fetus is not longitudinal. For the value of perinatal genetic counseling diagnosis, this is done for reassurance, increases options, antenatal fetal treatment, preparation for outcome, avoidance of obstetric complication, and selective termination. Indication for genetic counseling and perinatal diagnosis other than the age. Age is one of the main predictor for Down syndrome. As we increase in age, the female age is increasing, the risk of Down syndrome fetus is increasing, going down from 1 in 2,500, it goes down to 1 in 250 by the age of 45. So when we will do a genetic counseling or diagnosis test, we can do if there is a previous child or a family history of birth defects, chromosomal abnormalities, or non-genetic disorder, a previous child with undiagnosed mental retardation, a previous baby who died in the neonatal period or stillbirth, multiple fetal losses, abnormal serum marker screening results, consanguinity, and this is very common in our area, maternal condition predisposing the fetus to congenital abnormalities, a current pregnancy history of teratogenic exposure, a fetus with suspected abnormal ultrasound findings, a parent who is known carrier of a genetic disorder. So all of these are reason to initiate a diagnostic testing, genetic diagnostic testing. طيب, how we'll be doing prenatal screening? We have non-invasive and invasive models, and by this screening at 11 to 20 weeks, we do something called the knuckle screen or knuckle translucency screen, and we have the knuckle translucency screen with biochemistry. We do blood test from the maternal serum blood test, or we do just the maternal serum screen, or we do ultrasound, or we do the NIPT, the non-invasive pre-genetic testing, prenatal testing. And when we talk about the NT, the knuckle translucency, this is done in gestation between 11 and 14 weeks. The CRL should be between 45 and 84 millimeters. The image should have mid-sagittal view, as this image you can see. Also, image size should be more than 75%. The fetus should be covering the more than 75% of the picture. The neck should be in the neutral position, and the amnion should be away from the amnion. The fetus and the neck should be away, so it will not be compressed against the amnion. Also, maximum lucency in the ultrasound setting should be set, and calibers should be on to on. When we put the caliber the back of the neck of the fetus, it should be on and on, not in, on or out on. It should be on and on the lines that we are looking at here in the ultrasound. Fetal knuckle translucency, the significance of increased knuckle fluid, it could refer to chromosome abnormalities, birth defects like cardiac, diaphragmatic hernia, or genetic syndromes. Also, increased mortality is noted if there is more than 3.5. Up to 2.5 millimeter we consider as normal, but above from 25 and above, this is increased, and there is a risk of abnormality. Above 3.5, there is high risk of mortality or losing the pregnancy. What is the pathophysiology of increased knuckle translucency? There is abnormal or delayed lymphatic development, or venous congestion, or cardiac failure. The altered composition of extracellular matrix can lead to failure of the lymphatic drainage due to fetal hypokinesia, fetal anemia or hypoproteinemia, and at last the congenital infection. All this can be causes for having high abnormal or thick knuckle translucency. Other than the knuckle translucency, you might hear about knuckle fold. This is done after 14 weeks or 13 plus 6. And this is also an indication with the similar pathophysiology, but it is not reliable. It usually is not done. The diagnostic and the standard is to do knuckle translucency between 11 and 14 weeks. Going to the trimester, the biochemical markers, we have the pregnancy-associated plasma protein, pregnancy-associated plasma protein A, and this is produced by the placenta trophoblast, increases in 10 to 14 weeks period. It is lower in Down syndrome pregnancy, 0.43 multiple of the mean. So if you have low pregnancy PAP-A, think about Down syndrome. And this will be 0.43 multiple of the mean. What about the beta HCG? Free beta HCG is produced from the placenta. It's a placenta protein. And if it is higher than the normal, then this can be in Down syndrome pregnancy, and it will increase by 1.79 multiple of the means. We can do something called the combined screening methods, and here we can combine either the age with the beta HCG, with the pregnancy-associated plasma protein, or we take them alone. Also, we can combine the age with the NT with the knuckle translucency, or we take them all together. So here is the and the x axis. We can see that the detection method, and here we can see the detection percentage. So in this line, the one with the detection method, we can see that 30% only by age, as we mentioned, risk increase of Down syndrome by age. Beta CG alone can detect also around 30%. The plasma associated plasma protein alone can detect up to 50%. If we combine the age with two biochemical markers, we can detect up to 60%. Age and knuckle translucency, يعني ultrasound with age early in the first trimester can detect up to 72%. If we use them all, we can detect up to 89%. This is in the previous biochemical markers and knuckle translucency and age between 11 and 14 weeks. What about the three biochemical marker? If we do beta CG, alpha fetoprotein, and esteriol, this gives an age-adjusted risk. Yani alone, it is not meaningful. It should be related to age. And this is screens for Down syndrome in the second trimester, and also to NTDs, which is like the اللي هو الصلب المشقوق يعني as شو اسمها neural tubal defects, and this is done between 15 and 20 weeks. So it is later to the first combined biochemical markers. What is the limitation? It has only sensitivity of 70%. Specificity is 95%, with a false positive only 5%. Two reasons for a false positive: either wrong dates, and the gestational age is wrong, we are not doing the right timing, or there are twins. It can lead to false test. A new non-invasive perinatal testing is the NIPT, the non-invasive perinatal testing, which is the NIPT. I'm sure most of you have heard about it now. It is very common, and it is taken from the maternal blood. This test is a blood test, and it's a screening test. How it works? It works by analyzing the fragments of DNA from the placenta circulating in the mother's blood. This requires informed consent and maternal information, because it is all linked to the outcome. Also, the accuracy is about 99% in Down syndrome and trisomy 18, and a little less, down to 96% in the trisomy 13, and for 6 linked chromosome abnormalities. It is done from 10 weeks onward. Anytime after 10 weeks, and 10 weeks and onward, you can do this blood test. It takes 1 to 2 weeks for result to come. Also, it discovers the gender of the baby. The anomaly scan. This is another way where we do ultrasound screening. It's the detailed scan, and we do it at around 18 to 20 weeks, or from 20 to 24 weeks. This is the timing for the second trimester detailed anomaly scan. We talked about the non-invasive technique. We will be moving to the invasive techniques for early perinatal testing. We have two techniques, which is the CVS and the amniocentesis, and we'll be talking about them. For the amniocentesis, this is done by an ultrasound, placing an upper ultrasound. You can see the transducer on the abdomen of the mother. You can see the fetus, and there is a needle with a syringe, and it is introduced away from the placenta in the space for to take from the amniotic fluid. This is taken and sent for investigation. Also, we can do it through cervix, through transvaginal, through the cervix. We can take a sample. This is done at more than 15 weeks of gestation, not earlier, and takes 2 to 3 weeks for the karyotype to analyze the cells of the fetus in the amniotic fluid. The risk of pregnancy loss from the procedure is 1 in 200 and can get result of trisomy 13, 18, 21, and Turner syndrome in 48 hours with a fish fluorescent technique, the fish technique, which is the fluorescent in situ hybridization. This is a special technique, يعني زي a detector for a few number of trisomies or abnormalities, chromosomal abnormalities, like that trisomy 13, 18, 21, Luma Patau and Edward, and Down syndrome, also for the Turner syndrome. But this is only few. Are not all the abnormal chromosomal abnormalities, and for doing the full panel, you will take 2 to 3 weeks. But this is another technique where you do fast results in 48 hours. What is the other technique? It is the chorionic villus sampling, the CVS. This is performed between 10 to 14 weeks. It takes 2 to 3 weeks for the result. Pregnancy loss rate is 1 in 100, so it is higher risk. This is 1%. This one is 0.5%. It's done earlier, and we take sample not from the fluid, we take it from the placenta. So it is linked to limb abnormalities and also placental mosaicism is up to 3%, but little effect on the outcome. Assessment of a fetal well-being, maternal self-assessment of a fetal well-being. This is done usually in the third trimester, and it is done by different methods. Either we do NST or CTG, low non-stress test, or cartography graph. Also, we can or contraction test. Also, we can do ultrasound plus or minus umbilical artery Doppler. We do venous Doppler for the umbilical artery. Also, we can do other Doppler studies for the middle cerebral artery or the venous ductus or the venous or the ductus arteriosus. All these are kind of Doppler study, but the usual we do umbilical artery Doppler. Also, we might hear about uterine Doppler, uterine artery Doppler, but this is usually reserved for research, and it is done in the second trimester. It might give some prediction about some diseases, but it is not usually done or accurate. It is not done in the fetus, it's done for the uterine arteries or vessels for prediction of some diseases. Here we are talking about umbilical artery Doppler. Also, we can go for the contraction stress test, where we give a motivation or a medication to contract. There's no contraction, and then doing checking the heart and of the fetus by the NST. Thank you, and by this we came to the end of the first lecture.